the hemoglobin has normalized. Now it's not normalized yet, but it's almost there. Okay, all right. Okay, so that's the idea of the iron. So some of you said, no, why do should we continue to treat? You can read up. We see there's two things here. There is what we call as iron deficiency state and iron deficiency anemia. Okay, a patient will be iron deficient, but then not anemic because it hasn't come to the point where the HB production has been compromised. So it's iron deficiency state. Okay, HB is normal, all right, but the MCV might be slightly low. Okay, but then you also get iron deficiency anemia. So that's a point when the HB production, red cell production has been compromised, and then the hemoglobin level is also reduced. So then you need to uh, two things to correct. So if you have, that's for if you have, yes, treat if you are okay. So if you have and stop the source of the iron loss, either because of a loss or because of reduced intake or whatever, then uh, you need to correct the iron deficiency state, not just the anemia. All right. So you correct the hemoglobin until the normal, but then you continue treating with iron therapy until the iron reserves are what do you call, co- uh, replenished. That will take between 3 to 6 months. That's why our advice is that if the hemoglobin is normalized, you continue treating the iron therapy for another 6 months. Okay. Now, why is it so? Here, the genetic testing is also important because of this next issue. Right? The next issue, she has got a fiance who is confirmed thalassemia trait. So you need to know what kind of thalassemia she is. Okay. If the MCVC is 68, and the electrophoresis looks normal, then you have no choice. You have to do genetic testing because the HP electrophoresis cannot reveal alpha thalassemia. The alpha thalassemia can only be revealed by doing specific genetic testing to see whether the patient has that genetic lesion. Okay, so here is an issue because if she's a trait and he's also a trait, then you got to, counsel the patient, explain to them. So thalassemia is a very, the world is changing. The Malaysian health service are changing, but we used to handle all this genetic counseling ourselves. But obviously, as time change, people may specifically look for a geneticist. But then we still have to be equip ourselves how to explain. All right, the risk of the children being a carrier or being full-blown thalassemia. So we have to know this knowledge. The if they are both trait, both carry of a gene, what are the consequences? So you need to know that. Okay, I'm not going to spend time in here. There's a lot in the textbook. I think there's also been some discussion in PBL. All right. Okay, next go to the third one. Okay, this is second scenario, third question. Okay. Huh. I've got an interesting, I heard about this interesting comment. Uh, if a patient muntah darah 1 cup only, so why should the patient become hypotensive? Okay, all right. Remember, when a patient is bleeding into the stomach and continuously into the gut, you do not know how much she's slowly oozing and bleeding. But it come to a point she couldn't tolerate, so she vomited out 1 cup of fresh blood. But you don't know how many pints of blood she has been releasing into her gut. Okay, so there are sometimes patients who, if they bleed from the duodenum, they might not vomit at all. But then you got fresh melena and the HB drop, hypotensive, because it goes down. It doesn't come up. So your amount of blood someone vomits may not represent how much blood patient is actually losing in the gut. Okay. Uh, then there is this comment, everybody got this B12 folate. Time for me to change the question for next group. When I put this question up, nobody got it correct. Nowadays, everybody says, "Oh God," but when you listen to the argument, but that's where you see how much understanding that you have. Okay, now things that you need to. Okay, I've been talking. I'm talking to a wall, so I'm not sure. Are you all awake, or you all, are you all picking things up? Are you all sleepy or something? Am I?
We're
I
still
seem.
here, Doctor.
Okay, you are picking. Are you on? You are still in focusing, right?
Yes.
Okay.
Yes, doctor.
Okay. All right. Okay, I'll continue. Okay. So let's see. You see, when you have this, you need to know two things, right? One is that the blood results that you get, the hemogram that you get, these numbers, they are actually the average. Aha, be careful, eh? They are the average. So when you get 93, you get 89.7 femtoliter or 89.6, they looks like normal because this is the average. And it can be very difficult when you have an isocytosis. You see, so when you get RBC and isocytosis, some small, some big, some post-transfusion, some. That's why you cannot just make a judgment, jump, oh, this is normochromic, normocytic. You can't jump straight away. You got to actually look into the morphology. All right. Another thing is that when you have someone acute bleeding, they don't have iron deficiency anemia, acute bleeding, right? So this, as far as acute bleeding is still normocytic, normochromic. Okay. But then when you look at this morphology description, hey, you got hypochromic microcytic, you've got some normochromic, got cigar cells. Aha. So it means that, it looks like this patient has got hypochromic microcytic red cells also. So that's why it's always, whenever you got a full blood count, it has to get a better understanding of the picture. You need the full blood. You need the peripheral blood smear. You need a smear to have a look as well. Okay, but remember, look at the hemoglobin when she came, 4.6. Obviously, it's very low because that's the reason why she's hypotensive. She's been losing a lot. So people have transfused, support and bring it up to 9.6. Okay, now, and that's one point I want to raise. Now, the second point I want to raise is that um, the aplastic anemia. Now, most of you, aplastic anemia means the patient has got pancytopenia. The argument as I got is that, oh, the white cell is not so low. That's right. At one point it became low, but then here the white cells are not that low. So now the other argument about not likely to be aplastic anemia is this presence of nucleated red cells. And then there's a left shift with occasional myelocytes seen. Left shift with occasioning myelocytes seen. So it means that there is a. So it means that there are immature cells that are appearing in the peripheral blood earlier than what is supposed to be. So immature red cells, immature white cells. So this is what we call leukoerythroblastic picture. So you have a shift coming in. You don't see that in aplastic anemia. Aplastic anemia is a barren marrow. The marrow is, is so empty, so barren. 80% a hypocellular, acellular. Fats, 80% fat. It's like a sub-Saharan desert. No trees, nothing, not Katolistiwa. Okay, so you don't get this immature cell running out in the open into the peripheral blood. No. So that is the argument where you will not consider aplastic anemia. The other thing is that if the patient has hepatosplenomegaly, well, this patient don't have, so this fits in aplastic anemia. Okay, fine. So that's the argument that is not aplastic anemia. Now, some of you said acute myeloid leukemia, you expect to see plus 5% in the peripheral blood. No, that's not really true. When you make a diagnosis acute myeloid leukemia, the problem is marrow failure, meaning that the marrow failed to function because of this expansion of this blastic population, blast, young population of white cells. So when you have failed, then you have peripheral pancytopenia. You don't have enough red cells, not enough white cells, not platelets. So that's why you call bone marrow failure, not enough in the peripheral blood. And that, okay, obviously, in the very, if it makes life very easy, but some of these blasts in the marrow spill over into the peripheral blood. Fine. So life's easy. There's circulating blast, but not always. There are times they haven't spilled over yet. So the marrow, the blast is still inside the marrow. It's causing stress into the marrow microenvironment. Normal cells cannot grow, so that's why it's impeding. But you don't see anything circulating outside. So you cannot say no. This is not acute leukemia because we still have to do the marrow. Okay, so not well. Well, you can still think there's still a possibility. That's why I say this is a lot of things, right? Okay, now marrow infiltration by gastric carcinoma, you are very right. When you see this leukoerythroblastic picture, so it means something is disturbing in the marrow. Some disturbance taking place in the marrow, and all these young cells are flying out, or there is a demand. Okay, so you see, I give you a very simple example. So I hope none of you get offended. Okay, if you go to KL, for example, and then you see a lot of, maybe not now, sometime 20 years ago when I was in KL, you see a lot of Indonesian migrant comes in the construction service. They do all this, climb up the trail, make all these skyscrapers in KL. So why are Indonesians coming over to KL? Because there's a lot of economic opportunity. So they come. So there's a need. So people rush out. Okay, so you either the Indonesian come over because there is an opportunity, so they come over, or let's say if Krakatoa is threatening to explode, so if people will run out Sumatra, Krakatoa, and come over to Peninsula Malaysia, because far away. Okay, so two situations. So similarly, if you look at a marrow, just like you, let's say if there is a disaster took place in Kota Baru, and you guys are third-year medical student, haven't graduated yet, but then you are needed. Although you know a little bit of medicine, but we'll call you, come and help. So you all run over and help the disaster, save people, put in IV drip, whatever you can do. But you're not graduated yet. You're still a medical student, but we need you. Okay, so there is a demand. Okay, or let's say something happened to school in the kind of disaster, everyone run out. So run out into the outside the compound. Okay, so here in this situation, because she's bled, she bled and there's a stress. So that's one reason people come out. The red cells, immature red cells, so come out because the SB is so low. There's a demand for red cells, so they come out. So white cell, because of stress, so it comes out. Okay, or you can say there's a carcinoma infiltrating into the marrow space, disturbance, so come out. Okay, so that is the concept of leukoerythroblastic picture. I told you both, so you should remember, right? Okay, folate and B12 deficiency. So all of these were in our mind. Actually, this is a real case. All these were in our mind, and and that's why I put it out for you. Now, well, yes, you see, this patient is Down syndrome, and when we saw her, she was very sick. She hasn't been taking her food for some time. So, and she was thin, and you saw right, but no, PT was prolonged. But someone was saying intrinsic factors causing vitamin K deficiency. That is not correct. Vitamin K absorption is not dependent on the intrinsic factor. Intrinsic factor is only for B12 absorption, not vitamin K. To delete. Tak betul. Okay. All right. So, vitamin K is just overall the food, vegetables are less, vitamin K is less absorption. So, you got some coagulopathy there. And your calcium is also 1.62, 1.53. So calcium is also low. So that again is indicate there's an absorption. There's a intake issue. So iron deficiency. Maybe she's been breathing a long time. Difficult. It may not be because of a food. But then you got occasional hyperthermia neutrophil. Yeah, it could be. And then that over time she became pancytopenic. She wasn't cytopenic. So one of you was saying that folate is not pancytopenic. No, it's not true. See, B12 and folate are involved in nuclear maturation, and all nucleated cells will be affected. So it's not just, although red cell is not non-nucleated in the adult phase, but it is in the erythroblastic. In the normal blast is so nucleated. So nuclear maturation is impaired. So the cells continue to expand in the marrow, but they cannot divide. So that's why you get this megaloblast. The term megaloblast refers to all these young cells that are gigantic inside the marrow space. All right. So you don't see that in the peripheral, but you only get hypersensitive neutrophil. But in the marrow, you get that. That's why the term megaloblastic anemia came from. So the megaloblastic giant, megakaryocyte, myelocyte, so everybody is affected. So that's why you can get pancytopenia. But obviously, you start with red cell, then you continue with low white cell, and eventually low platelet count. Okay, so pancytopenia is a feature of both B12 or folate deficiency. B12 and folate, they're interlinked, all right? Okay, all right, so I've got that corrected. What else? All right. Okay, so I guess I've touched on most of the things that I've heard in your discussion. All right. So, anything else that you want to discuss? Anything else you want to clarify? Well, anemia is a big topic, so I just you just here and there, and we just collect few things. Yeah.
Doctor, I have a question regarding your quiz on individual.
Yes. Yes.
Um, there are scenarios that people who get in accident and then the hemoglobin normal, but patient become pallor. Can you explain that more? I don't understand about that.
Okay. You see, this is just in the. I'm talking about the first 1 or 2 hours. Yeah, first few hours. This is your understanding of what hemoglobin is. Now I may have to draw something. Okay, let's see. I have to withdraw this. I share this out, and I share you something else. Let's see. I need to draw something. Okay. Okay, my good old paint. Okay, you seeing my paint?
Yes.
Okay, so all right. So let's say what is hemoglobin? Hemoglobin is gram per deciliter, right? Right? Wait, I need to see a response. So now I not think I'm talking to the wall. Is that right? Okay. So gram per
All right.
deciliter. Right. When you say gram per deciliter, it is a measurement of concentration. Got it?
Yes.
Okay. So concentration. Okay. So when you have a jug, let's say when you have jug of syrup. Okay, this is a jug of syrup. Okay. So, and this syrup is red. Aha. Oops, sorry. Controversial. Not a good drawing, I suppose. So he has to close everything. Okay, so let's say this is a jug. This is a red syrup. Okay. Now, when you say concentration, that means the color is red, right? Okay. So let's say if someone bled, right? And when they bled, so let's say 1/3 of this blood has poured out from the bottle. Okay, got it?
Got it.
Okay. Now tell me, would this syrup color change?
No.
No. Now immediately no. Right? Immediately no. Immediately no. But then because this patient is hypovolemic, then the body will try to compensate. All right, what will compensate by flowing by shifting plasma, right, from the intracellular space, from the extracellular space, interstitial space into the vascular compartment. Ada faham?
Faham, faham.
Okay, so when this fluid shift inside the vascular space, now you have the denominator. Now what happened is that your gram has gone down. Okay, your gram has gone down. Initially, how am I going to do this? Okay, initially, let's say you got 12 gram. Oh, merah pula dah. Okay, never mind. 12 gram per deciliter. So deciliter per 1 deciliter. So when you pour out, all right, pour out, let's say dah buang, so your half gone, you become 6 gram, and then your deciliter to becomes 0.5 deciliter lah. Okay, so in terms of concentration, these two is the same, betul tak?
Betul.
Okay, but then you add in and back to 1 more liter because your fluid comes back inside. Jadi apa jadi? Now pucat lah. Okay. Sekarang dia jadi bila dah cair, so merah tu jadi warna lain lah pula. Merah ni lah. Faham? Oops, sudah terlebih. Okay. Faham lah kan? Then so usually immediately after an accident when you do so HB HB pun tak rendah pun, HB lebih kurang je. So you think tak ada anemia no, but then you do like say like 3 or 4 hours later the HB drop lah. Okay. Alright. Any more? Sebab tu usually lah when you say sample salah ke, tak salah, you have to check. Kadang-kadang botol emergency semua sibuk-sibuk, ambil darah emergency, bawa ambulans masuk lah, casualty bong situ-situ. Because actually beri contoh tu sebab immediately you take the blood kan. And then sometimes you orang accident bawa masuk hemoglobin you buat tak berubah pun, hemoglobin okay, must be careful. So hemoglobin may take some time for the readjustment, so you don't see. But patient hypovolemia, you have to give blood. Okay.
So even at the time, contohnya kan kita tu sometimes baru hemoglobin drop. So in term of management kena bagi jugalah.
Especially kalau you tengok orang yang patah femur tu, femur, tahu femur? Your year 3 kan. So patah femur dia tak keluar darah pun, tapi thigh besar kan. So your thigh tu kompol 2-3 liter dalam boleh. Awak tak perasan. Ataupun intra-abdominal dah tak keluar. So you have kalau hypotensive ada nampak, you have to give blood lah.
Oh, okay.
You jangan tunggu HB tak rendah pun lah. So you jangan. HB force. So sometimes you look at the pale because dia dah hypotensive, dia kurang blood flow, so you can pale. You see blood is lost inside the stomach, so you have to bagi. Okay.
Alright, thank you, doctor.
Okay. I am from my past experience, most of you already got a bit tired by now. Okay, now if there's no more question, all right, not going to push any further. If you don't mind, there's a feedback button. Can you please give your feedback? I know that I have to give a warning for next group. We may have to ask everybody to bring prepared with their laptop and their or desktop. So I'm not sure. The next question I want to, besides one of you, siapa lagi pakai iPad? Is iPad the issue? Ada lagi ke siapa pakai iPad?
Saya pakai iPad.
iPad boleh? iPad you boleh? Okay. So bukan masalah iPad lah. For handphone memang tak boleh lah. Okay, iPad boleh. Okay. Alright. Any more? Tak ada? Any more question? Tak ada? But I'm not seeing okay. But I'm not seeing too many participation. There are only 4 or 5 in the third group, 3 or 4% in the second group, but first group got more participation. So I think next time I have to make sure everybody comes in with their video on. Okay. All right. Please give your feedback, and hope to see you again in the hospital once when the COVID quarantine has been released, so you can come and join. Okay. All right. Bye. Assalamualaikum. Okay. Bye.
Thank you, doctor.